Good evening. Welcome to HeartBrothers webinar on the National Organ Care System Program, NOP, a transformative practice to increase solid organ transplants in the US. And our featured speaker is Dr. Tamer Khayal from TransMedics. My name is Hamid Madavi. I'm a member of the board of directors of HeartBrothers. And just want to, before we get started, just go through some quick introductions and some best practices for webinars, and go from there. Just a little background, Team HeartBrothers, who we are, we're patients, just like you, traveling the heart failure journey. After our transplants, we've decided to give back to the heart failure community. Our mission is to support heart failure patients and their loved ones navigate a life with heart failure and all its challenges. I want to thank TransMedics Corporation. They're not only being the featured speaker on this event, they're also graciously sponsoring this event, and for that we are eternally grateful. They're a great supporter of HeartBrothers and our mission, and a big thank you out to them. The disclaimer is just basically that we're going to provide on our webinars medical information, share medical knowledge, talk about various treatments and approaches, but by no means this is a substitute for your own physician. Please, please, please contact your doctor, your treatment center, and get the proper medical guidance and treatment for you and for your specific conditions. Thank you. For better viewing of a virtual meeting, please go to the full screen mode. To make comments, utilize the chat at the bottom of the navigation panel. And then for questions, please put them in the Q&A session, and we'll make sure that we get them to the panelists and we will answer them. So the speaker tonight is Dr. Tamer Khayal, MD. He's Chief Operating Officer of TransMedics Corporation. And our host tonight, besides being a dear friend, Melissa Parente, MBA. She's the Executive Director of Surgery and Transplant Services and Interim Vice President of Surgical Services, Surgical Specialties, and Neuroscience at Tufts Medical Center. With that, I'm going to turn it over to Melissa. She'll be the moderator for the evening. And Melissa, take it away.
Great. Thank you so much, Hamid. So happy to be here. As Hamid said, I serve as Interim Vice President of Surgical Services, Surgical Specialties, and Neurosciences, which of course includes heart, kidney, and liver transplant at Tufts Medical Center. Transplant is near and dear to me. My father just celebrated his 3-year anniversary of his transplant, heart transplant, and he's doing fantastic. So always happy personally and professionally to be a part of these conversations. Thrilled to have Dr. Khayal here with us today. He has 22 years with the company TransMedics, started leading their research, their clinical research endeavors, and as Hamid said, is now the Chief Operating Officer, Chief Consumer Officer, and we're looking forward to hearing his presentation. I'll be monitoring the chat and the questions, so feel free to pop anything in there at any time, and we will take those after Dr. Khayal is done with his presentation.
Thank you so much, Hamid and Melissa and the HeartBrothers Foundation and everyone attending this session. It's a pleasure and an honor to be here, guys, presenting to all of you and addressing your questions. This is a long journey that took us 25 years. This is a quarter of a century in the making to get the product to market and really transform the practice as you'll see me describing today. So with that, and if you would allow me, Hamid and Melissa, I'll start sharing my slides. So welcome again, everybody. And what you see here is not a slogan. We're really redefining what's possible in organ transplantation because—
Wait, hold on, Khayal. I can't see them. I see the introduction slide. Hamid, do you need to stop sharing? Oh, there we go. Perfect. There you go.
Can you see it now?
Yep.
Awesome. So redefining what's possible in organ transplantation, because today, or as it used to be, because today it is changing. organ transplantation, starting with heart, but also all organs, are really limited by the cold storage limitations that you see here. Time-dependent ischemia, there's no optimization capabilities, and you cannot assess the organ beyond the initial assessment that took place in the donor body. So what this led to is significant underutilization of the consented donor organs. So only actually 30% of donated hearts are transplanted today. And the outcome still is suffering a little because 30% of those transplanted hearts still have complications. And we have identified cold storage from day one of our research and development in TransMedics as the biggest limiting factor to expand utilization of organs. And that's why our focus from day one was to have a physiologic product, a physiologic nature of maintaining organs on our OCS organ care system, meaning that the heart is beating, it is well perfused with warm blood perfusion, and it's getting the nutrients it needs. So it's no longer dependent on the time limitation that ischemia impacts it with. And the outcome is no longer held hostage by regional distribution of organs. Now we can take organs across the country, as you will see, and we can assess organ better, and we can actually manage the organs better, so treat it in some sense. So this is this modality that you see here, it's for all organs, heart, lung, liver, and kidney. We've been approved by FDA in the US for heart, liver, and lung, and hopefully soon we'll start our clinical trial for the kidneys. This is what our product looks like for the lung, heart, and liver. It's a hardware and disposable piece that's one-time use, and that disposable has all the sensors built in already, and it's meant to be very easy to use. We get it out of the box, put it in the system, in 2 minutes, we're ready to retrieve the organ. And now on that wireless monitor, we start monitoring all the parameters that clinicians would be interested to see to evaluate this heart en route from donor to recipient. So there is no ice involved here. We just, after retrieval, heart is being instrumented with 2 simple cannulas on our system, and solutions is being administered, plus the normothermic or warm blood perfusion of oxygenated blood. So the heart feels as if it never left the body, and it continues to be in this state regardless how long it stays in OCS, and regardless where the donor or the recipient is. We don't have time or distance limitation. What this resulted in our clinical trials prior to approval, and that's what actually led to us gaining the approval for the heart specifically, since we're focused on heart today, we've increased utilization rate to 81% instead of 28%. And for DCD donors, excuse me, we've gone up to 89% from 0. There was no transplants of donation post-circulatory death in the US until OCS was introduced in the picture. And that's a huge, significant milestone in transplantation for transplant patients to gain these organs that work very well, similar to any organ that's being transplanted today. But before OCS, you couldn't test them. So the risk was too high to try and take these organs. And not just the utilization rate, the outcomes were also matching what we expected, because warm oxygenated physiologic perfusion enables the organ to function better. And hence the outcomes should be better. And we've seen on all organs, especially the heart here, 65% less complications in severe primary graft dysfunction, and 95% survival after DCD, and we're monitoring this data. This is published data already. We have even better data today that we're going to present at the next ISHLT that's happening in Denver, Colorado in April of 2023. So the outcomes could not be better, really, given that these organs before OCS were not even considered for transplant at all. So physiologic perfusion and warm normothermic portable. The key is portability, because you cannot just ship organs on ice and receive them and then perfuse them and think you'll regain the same outcomes. It won't be. And then start of perfusion immediately is a key aspect of the successful results that you're seeing here. And then we went beyond our technology and our product to identify issues in the transplant field that are limiting the utilization of donor organs and having more patients have access to more organs on the waiting list. And you see here, there's two main entities that are involved in transplantation: transplant center and the organ procurement organizations. And the transplant center really has a ton that they're managing. They have to manage the patient pre-transplant and post-transplant. And then retrieval, they have to have an assigned team going out, retrieving these organs, or coming back empty-handed if they don't have any means of assessment beyond what's in the donor chest. Or in fact, sometimes they just have to turn down by phone because there's no one available to go out. So there's a huge constraint on the transplant center resources that are very focused on the patient, as they should be, on the recipient. And we want them to stay focused there. And the OPO is also under a lot of pressure to improve thoracic organ utilization, heart and lung, to change these percentages that I just shared. So TransMedics stepped in and said, all right, let us extend our teams, invest heavily in having teams across the country. And when I say teams, I mean cardiothoracic surgeons, and for liver abdominal surgeons, our own clinical specialists, our technology, and a logistical network that we can utilize to access any donor in anywhere in the United States, and even extend to Hawaii and Puerto Rico and Alaska, bring these organs to the matched recipient, regardless of the distance and time needed to do this match or to deliver this organ, while we're in control of the quality, which is a key aspect now, that our team is maintaining the quality of these organs, because we're avoiding the learning curves that any new transplant center, when they used to use our product on their own, you had to be trained and be available to do the process. So here, TransMedics is in quality control of the organ, and we're using our team as an extension of the transplant center team, as well as the OPO team, to increase volumes of organs delivered and improve the outcomes. And this really couldn't have lent itself better to really see organ transplant volumes increasing. We're seeing this across the country, across all three organs, heart, lung, and liver. And from DBD and DCD, our rate of usage is really 50% each. So 50-50 split, the DBD, DCD across all three organs, with great outcomes. That's even better than what I shared with you. And hopefully you'll see abstracts coming out soon and presentations at the ISHLT. Reduce the learning curves, as we said, and enable the programs, transplant programs, to do more transplant without overloading their currently overburdened resources. So this map here shows you what we needed to do to be able to achieve this vision that's now in full practice, not just a vision. This has been happening over the last year of our commercial existence very successfully for heart, lung, and liver. So every circle you see and every city identified, plus two more coming on the left-hand side. We have one city in Seattle and another one in LA. Every city you see here has our product in a location that's housing it, a cardiothoracic team that's on call 24/7 that works for TransMedics full-time, and an abdominal surgical team, retrieval teams that are also working for TransMedics full-time. So, and this is all coordinated by a central team of transplant coordinators that's 12 men and women strong, plus a logistical network that's supporting the transportation, ground and air, with different vendors across the country. And what this is enabling us to do is really now, this is just an example. These are 24 cases, if you count the lines on this map. I had a hard time counting them, but these are 24 cases that shows you that we've gone for all organs, heart, lung, and liver. We've gone as low as 180 miles and as far as 4,700 miles. Organs across the country have been transplanted successfully, from Hawaii to Duke, from Hartford to San Francisco, from Puerto Rico to the East Coast. We've gone everywhere with our system, with our process now. It's not just a product, it's a full process where our team is involved from the minute the transplant center gets a call that there is a donor offer. They contact our hotline that's working 24/7, and we deploy our resources from the closest point to that donor offer to bring it to the matched recipient at their hospital. So really, we're overcoming boundaries of time, distance, type of organ indication. So any indication we can put on OCS, assess. And if we have any concern, we're going to relay this to the transplanting team who has the final say once we arrive at the hospital in accepting on declining this organ. And so far, our results are phenomenal for utilization rate, even much better than what you saw. And our outcomes are even better than what I presented. And that's what we'll be sharing at the next ISHLTs. These are just examples, but we've done hundreds of those cases since commercial approval, plus the thousands we've done in research and development before the commercial approval. So this is what we mean by we're changing the practice and we are changing what's possible in organ transplantation. What's known to have been possible is now facing a new definition. We can go further, longer, more organs, better organs, no overburdening of transplant hospital or OPO resources, given that our team is helping on both ends. So I'd love to stop here and open the floor for questions.
Great, thank you so much. We do have a few questions in the chat. The first question is, for heart transport, are the benefits of using a separate pumping mechanism versus using the heart to pump the perfusion? So I think what that means is, I think they're asking, like, what's the benefit of maybe the pump versus the old-fashioned way versus, I'm not sure what else.
Okay, let me try to decipher what I understood from this question. You still need a pump to pump the warm blood to the heart because the coronary system, the coronary vasculature, needs to be perfused in a pulsatile fashion through our pump. And once this happens, now the heart pumps back the blood to the system because we want to be able to control in that individual or organ-specific pumping mechanism to control the pulsatility and the perfusion pressure of the coronaries. Both are key factors for the success you're seeing here. We're doing something called LVH hearts, left ventricular hypertrophy hearts, that were not transplantable before OCS above certain limit of thickness of the myocardium, which is 1.3 centimeter or 13 millimeters. Because once they're on ice and you put them in a recipient, now the recipient will see the impact of ischemia on that depth of the thick myocardium. Here on OCS, through our pump, to address the question with a specific example, we can control the aortic root pressure for perfusion of that septum. It's thicker than normal, increase the pressure, hence deliver the warm, oxygenated, nutrient-enriched blood that's pulsatile to the entire thing throughout the transport time. So when you take it down and put it back on the patient, it's now hasn't suffered the ischemic change and it was fully perfused throughout the thickness. So yes, a pulsatile pump is key to deliver the warm perfusion to the heart itself, not just dependent on the heart to pump blood to itself as it is in our body.
And I think when I think about kind of how this has changed over the many years I've been in transplant, you know, at first we were putting hearts in coolers and we had no control of how cool the ice was. And maybe a little piece would get a little bit like freezer burned in layman's terms. And then there were some devices that would hold the heart in just kind of like a static temperature monitored fluid. And that was way better than the ice. And now this is really kind of the next thing that is way better than what we've ever had. Next question, it comes from Roger. Thank you. Should we be seeing reductions in wait time or reductions on transplant lists?
Yes, we're starting to see this, meaning reduction in the waiting lists at the institutions that are growing their volume significantly. But I want to clarify the waiting list issue. Our expectation is we're hoping to see the waiting list actually expands, increases in volumes and numbers until we're able to satisfy the bigger heart failure population that's currently may not be included. we're hoping that with our system and our vision and our process, that when we double the heart and lung transplants in the US or triple it over the next few years, that as we take on more patients from the waiting list and get them transplanted, that now the centers have the flexibility to enroll more patients that at this point, they couldn't enroll them because of a different criteria that can change in the future. So the waiting list should grow until all heart failure patients that benefit from a heart transplant have got their heart transplant achieved.
Great. Another great question from Roger. How is supply and demand working? Is there enough money to purchase equipment? Do you have enough staff for rapid expansion? Are hospitals prepared for and interested in getting access to the equipment? So Tamer, you maybe the first part, and I'll take the second part from the hospital perspective.
Sure. Yes, that's a great question. Supply and demand. We were facing issues with our own supply chain internally to be able to meet the demand that's growing significantly for all three organs. But we're overcoming them slowly but surely, and we're hoping from the beginning of next year, we internally at TransMedics will have a much better control of our supply chains for the product itself. From teams across the country and having our launching points that you saw on the map, we believe we've satisfied those regions, and we have enough resources to be able to deliver on every mission, on every donor offer for all three organs, and we'll expand as needed if need be. But I think we've realized the hotspots are for donation and where the hotspots are for transplantation, and we made sure that we cover all these strategic locations across the US from east to west coast. So I'll stop here and leave it for Melissa for the other half of the question.
Yeah, I would say hospitals. So this is a little bit new for us, right? So we are used to doing everything ourselves, and we, the collective we, do it better than anyone, and farming that out feels scary to us. But the reality is, when we've started researching this, the people that are hired by TransMedics are actually more expert at putting the hearts on this pump than our own surgeons, because they may have done it 50 or 100 times, whereas my surgeons may have done it 2 or 3 or 4 times. The other really beneficial part to this setup is that I don't want my surgeons flying to California when they could be in the OR doing another case of a patient that urgently, desperately needs them. So when we started looking at this at Tufts Medical Center, that was really more of a driving factor, was keeping our surgeons in the operating room doing what they do best, and then having someone else who knows how to do this better than us go and retrieve the organ, bring it back to us. We, of course, still have full power to say we don't want it, or it's not right, or something's wrong with it. That hasn't happened to us yet, but it certainly could. And it's just a more efficient way to transport hearts around the country at this point. The next question is from Mark. Is there an aggressive effort to increase the number of transplant hospitals that participate in OCS?
Any transplant hospital can call us, and yes, the numbers are growing. There's no specific criteria, since the beauty about the NOP, the National OCS program, it gives us at TransMedics a sense of comfort that we are in control of the quality of the organ being delivered on our system. So any hospital can call us today and ask for us to go bring them that organ, and there's no issue on our end. We'll have our team deployed, and we'll deliver that organ and give them full feedback. So the numbers are growing for heart specifically. I would say more even than the lung and the liver for centers that have been adapting this process and using the National OCS program.
Mike Ashworth says, past experiences have shown that when more than 3,000 heart transplants are done in a year, results usually fall off. Can you comment?
Absolutely. Great question. Yes, and you would expect this because historically, these transplant programs were forced to, or to increase their volume, they had to go longer distances, and they had to go after organs that could be perceived as extended criteria donor organs that may or may not be appropriate for transplant. So to increase the volume, you had to take risk. And with risk comes declined outcome. here on OCS and using our national OCS program, we're eliminating any risk, because regardless of the distance or time or riskiness, if you want to say, of the organ, you'll have full visibility and you'll have full assessment of that organ in a very methodical and objective way on the system prior to transplant. So you can, as we always say, you can safely increase your transplant volume as you'd like to, double or triple it, which was in the past, there were two contradicting variables. It used to be always to increase volume, your outcomes are going to get a hit. Today, we're changing this to no, increased volume actually improves outcomes of your hospital.
So Melissa, I had a couple questions. I think as a panelist, I can't type my questions, and so I'll just verbally ask them. So Dr. Khayal, obviously this is a change, a departure from the structure that currently exists. So, so how are the OPOs managing this? And then there's a second part to this question, that originally the regions for the OPOs were set up geographically based on some proximity, like region 1 is the New England states and maybe Eastern New York and so on and so forth. Since now the barrier of time has sort of disappeared to some extent, do we see that whole process of allocations and priorities and all that start looking at it more as a countrywide rather than a region-wide?
Great question. Thank you, Hamid. So one, I'll address it in two parts. One, we have been not just seeing, but we've been experiencing significantly that our team has been more than helpful to transplant programs and equally as an extension of their teams. We're just adding resources to the system that really badly needs resources, needs skilled resources, not just resources, in addition to our product. So technology and skilled resources. So our team and product are acting as an extension of these teams. But two, more importantly, the new allocation system, from what we're seeing across the country, has dramatically shifted the organ movement from what we knew and OPOs knew as 70 to 80% of any OPO's volume annually was local, to the complete opposite. 70 to 80% of donor offers in most OPOs across the country are called imports. They come from outside of the region. And this is where our system and our NP is really lending itself very efficiently to help address these new expansions that's making allocation a national system rather than a regional system. And that's why our program is called National OCS program, because it's all based on national sharing of organs, not just regional, which is coincided to be happening also with the new allocation system in the OPOs. So I think, and I believe we're helping the change that's aiming at doubling and tripling volumes of transplants in heart and lungs in the US.
And I think from the hospital perspective, for us to hire several more heart transplant surgeons to be able to do this would be really challenging. So our experience at Tufts this has been really like a really helpful extension of our team to be able to do that more volume for our patients without having to wait and find that perfect heart transplant surgeon, because as you all can imagine, they're not that easy to find these days.
Yes.
Roger has another question. Keep them coming, Roger. We're happy to answer all of them. Just to clarify, the hospitals don't have to acquire any equipment. They just have to express interest in receiving organs via TransMedics OCS. Hospital staff, admin, and clinical would have to be oriented to how it works and all of that, right? So again, Tamer, if you want to take the first part, I can take the second part.
Yes. Yes and yes. You don't have to, no one have to now acquire equipment because it's under TransMedics control and use from our different launching points. And we have delivered organs, livers and hearts to hospitals and lungs to hospitals where they either have been introduced to the process, or sometimes when it's an expedited offer, they need our help, we'll step in, even if this is sometimes the first offer and the first transplant is the introduction to the program. That's the beauty about this program, is we don't need to invest time and effort and resources and budgets in the initial setup of a program to be able to use the OCS, but we're stepping in to make it available to any hospital. So Melissa, please, from your
and I would say, like, the only kind of learning on our part is really, it is obviously different to take a heart off this pump, but we have support, than it is to take a heart out of a cooler. And our staff, we've done in-services and trainings, and there have not been any issues. They do some pretty complex stuff in the OR, so they seem to pick this one up as well pretty easily. Next question, is it possible that this would be included as part of a national system that is supported by policy, CMS, HHS? Yeah, I think you did, Tamer, I think you sort of kind of already touched on this.
This is already our great question as well. Reimbursement, because of course reimbursement is a key aspect of the whole process. Our product already is reimbursable, and services. So the entire process of organ donation is reimbursable by CMS under organ acquisition cost center to any transplant hospital. So the processes already exist. It hasn't changed. It doesn't need to be changed. And we're keeping CMS and also private payers very close to what's going on and updating them. And they're very supportive, actually, to see that more patients are gaining access to transplant, because believe it or not, transplant doesn't just benefit the health of the patient, but it also benefits the economic status of the community. So a payer would benefit financially from the heart transplant that takes place, or any transplant for that matter. So they're very supportive of increasing volumes, and they're very happy to see that we're investing resources to achieve this goal.
Yeah, and I would just add that I've been part of a little bit of research related on the kidney transplant side. Insurance companies really understand that taking a patient off dialysis, and it would be similar with a heart transplant patient with all the medical care that they need, they know the exact day when they are breaking even on the transplant from the dialysis. It's something like 2.45 years on the kidney transplant side. So if you have your transplant for 2.45 years, the insurance company is doing better with that than they would be paying for the dialysis. So I think insurance companies are pretty pro anything that increases transplant. Next question from Debbie. I am a DCD heart recipient. Thank you, from MGH, 2 years out. What is the issues with kidneys and your machines? Before Tamer answers that, I just want to say, in Boston, we have a very friendly, competitive dynamic with the other transplant hospitals, and I do have to commend MGH. They have done a really incredible job adopting this new technology, and we really applaud them for that. They really led the way in New England.
Well, Debbie, thank you. And we really are happy to hear that you're doing well and you received the DCD heart transplant. And yes, kidney will be next. The reason why, in spite of me in our lab 20 years ago when we started doing the research work, we started with the kidneys actually. But we've seen that kidney, there is always dialysis that takes place post-transplant. It's a modality that's available for any patient that relieves the primary graft dysfunction issues. Whereas the heart, lung, or liver, the need is so high and the alternatives are not as good as for the kidney. So that's why we focused our efforts on heart, lung, and liver first. Kidney is coming next, and our goal over the next few years that we will be able to address the dialysis issue even. So kidney transplant should not require dialysis as long as you got the kidney on homothermic machine, pulsatile perfusion. It's going to take us a little more time, but since there is an alternative, we shifted our focus to be first on thoracic, then liver, then kidneys is coming next. Hopefully, we're hoping to start the clinical trials end of next year, beginning of 2024.
Great. Roger asks, main offers must be complicated. Do you have to consider by region and status listed?
Clarification. We, TransMedics, we don't make offers. The offer is something that's matching process that works as is today between the OPOs and the receiving hospital, where the patients are matched. We get the call once this process is finalized. So the transplanting program would call TransMedics and say, I already accepted a donor offer for my patient X that's out in the West Coast. I'm here on the East Coast, and I want you guys to go bring me this on OCS, and I will notify the OPO you're coming on my behalf. So we TransMedics, we don't make offers. We just respond to transplant program requests once the offer has been matched already.
And just to add to that, the actual offer process that does go through our local OPOs and in accordance with all the national policies, it is really complicated. People often think it's like a deli line, like you get a ticket and you're number one, so you're going to get called next. It is nothing like that. At any given time, you could be number one for an organ and then be number 478 for the next organ, just based on all the clinical criteria, matching, size, cross matches, antibodies, all of those things. So it's a fascinating and sometimes frustrating process to be part of. Next question. Policy question. Could CMS require that hospitals participate with the NOP?
It's up to CMS. I think this requires a strong body of evidence that shows benefits to patients. And that's why TransMedics from day one, whether in clinical trials or post-approvals, we are very keen on collecting post-approval data on every patient, not actually on every organ that touches the OCS, transplanted or not, under a registry structure that's being supervised by leading academic institutions in the US, one for heart, one for lung, and one for liver. So with these, we're hoping with the publications and data, a body of evidence that we're going to collect over the next couple of years or few years, that this potentially can result in a CMS direction of mandating this to become the standard of care. We're far from there, but the process is in place to achieve this if and when needed.
Great. Mike asks, how do you overcome resistance to the use of the organ recovery system? Basically, how do you open up a new market or a new hospital?
One, we're called organ care system. We're not organ recovery system, just as a correction. Organ care system, OCS. And yes, of course, we faced resistance initially. There's nothing that happens easily. Otherwise, I wouldn't have a job. And my job was to overcome these resistances. So one, the initial resistance is too expensive. I have no idea how to recoup this money back. And I don't know if this is even feasible to recoup it back. And we were able to show that there is a reimbursement pathway that can get you your money back as a hospital, and that it's been working with our system during clinical trials and commercial fees. Two, the question we got initially, how can I trust your surgeons? Who are they? How can I trust this process? You're going to deliver organs to me and expect me to transplant them blindly. And we said, no, that's not the case. You're going to have full visibility from donor chest until the organ is in your OR, and you will be the final, you meaning the transplanting clinical team, surgeon and or cardiologist, or mainly surgeon, you'll have the final say to accept or decline this order. We're going to give you our feedback and say, based on these parameters that you are aware of or not aware of, we're recommending for you such direction. And you look at them, look at the heart, do any testing you want, and you accept it or decline it. So initial change is not easy in any practice. Talk about heart and lung transplant and cardiothoracic surgeons. And change that comes with a cost is even much more difficult. And I'm glad that we're overcoming both with demonstration. The key is to deliver good outcomes and more organs. As we started, this has been our vision from 25 years ago. When a transplant center that initially had these resistances start seeing that it works, that more organs are being accessible, more patients are being transplanted, outcomes are as good or better, it becomes really a no-brainer.
Yeah, I would just add that, as you can imagine, the heart transplant community is a relatively small one on the physician side, and they talk, and I probably get 2 or 3 calls a week from other transplant hospitals saying, hey, we know you guys are doing this. How's it going? Is it really all they say it is? And I think importantly with what the patient's goals are.
Melissa, you froze for a bit, and I don't know if it was my computer or just, so if they didn't hear the answer, you may want to repeat it.
I think it's your computer. I heard it fine.
Okay, great, then.
Perfect.
Perfect.
So I think we've answered all the questions we had in the chat. Certainly want to give folks any other opportunity. We are yours until 6:30. So if there's other questions, we're happy to answer them.
So this is more a question about the equipment itself. When you are taking a heart from the donor into your machine, I think the old process was the heart was somehow chilled and put in a sort of suspended condition, and then it was. So do you guys just directly basically act like almost like ECMO and take over for the heart, so it never gets chilled? Or
I mean, that's a great question. Great question. I wouldn't say chilled, but we have a specific solution, flush solution for donor hearts in donor chest that is introduced to slow down the metabolism of the heart until that half hour of cannulation, instrumentation, retrieval process is done, and now we reanimate it in our system. So it's not cooling down as it's used to be known using ice or very cold, very strong cardioplegia, but it's a specific solution that we're using that enables the heart to lower its metabolic demand for half an hour until we put it on our system and then immediately start the warm perfusion. So no ice storage involved.
thank you, thank you.
Apologies, my son's tooth just fell out. He's bleeding a little bit, so
No problem.
So to the guests, any other questions?
Oh, here's one more. This seems frustrating for those at hospitals that do not participate. Any suggestions on what I could do as a patient waiting on a list to encourage participation?
Just ask your surgeon and say, guys, I heard this is available, and it's as simple as a phone call. Just ask the question and see what they say. And I believe now there are multiple centers that can receive you as a patient. I think referrals can happen anywhere. So larger volume centers or average even volume centers are usually the ones wanting to grow their volume more, and maybe you have better chances there. But talk to your surgeon and see what is the obstacle of them using our system.
And certainly if they're not willing to start up, you can always dual list. So patients are always entitled to be listed at multiple centers. So you could stay listed at your center as well as another center that did use the OCS system.
That's even better. Thank you for the clarification, Melissa. And Debbie, I want to thank you. I saw a comment from you. Thank you so much. We are really very happy for you and excited about that. I want to say that in my experience, I had the honor and pleasure to be on the first heart in man on OCS. It was a woman. Our first heart transplant ever, first organ on OCS ever was on January 17, 2006 in a small town with the largest at the time heart transplant center in the world, Bad Oeynhausen, Germany. And Mrs. Viba, 5 girls, she had 5 girls, and she's still doing phenomenal since 2006. So since that day, my entire life changed to really become committed to this, because there's nothing better that you can see than a patient before and after transplant. It's really transformative. And for me to see that we were able to help that very nice lady receive the gift of life and see her girls happy with that outcome, since then it's been a phenomenal journey. So I just wanted to thank you again for your comments and kind words, and we're so happy for you.
And one more question, can you envision a future where there's like a bank of organs?
That's actually a great question. I think it's going to happen. I think at some point, when we have more access to more donor offers that are usable, being able to assess these, we can station them in our launching points until the matching process is finalized. I think it's feasible. I think this is once the volumes just show itself in the donation side and the waitlist side, I think it will be the way to go. It's just stationing organs until their turn comes. Instead of donors, it becomes an organ and it's assessed and the data is being shared. In fact, we're working on our system for next rev that will enable even more communicative capabilities so that the transplanting center can see the data real time, can interrogate the system. They don't even have to talk to our team. They can see what's the status of the organ, ask questions, and instigate a question to our team. So all is in the works, and I think technology is making lives much easier, and we're implementing and planning to implement the most efficient way of retaining the organs until transplanted.
I can certainly tell you hospitals would be thrilled if that was the case, because low on the importance level, but it's always challenging when we have to cancel a bunch of scheduled knees and hips and things that are booked to go into the OR because we have a heart coming in. So if hospitals could ever get to a place where we were doing this as an elective surgery, that would be a great accomplishment for all of us. Glenn asks, how long can you maintain organs? Is their time longer than 96 hours as it was 5 years ago when I received my heart through OCS?
For hearts, it was never 96 hours, Glenn. This was for hearts on ice. According to the ISHLT database, any minute above 90 to 120 minutes is really going to have an outcome, an impact on the negative impact on the outcome. So in our system, we've been able to transport organs in the commercial setting, hearts that got transplanted, for up to 12 hours of perfusion of the system from the East to West Coast. That's unheard of in heart transplantation in the US. Whether it's a CD or a DBD or a young donor or an old donor, it doesn't matter. Our indication and our time is open. And as long as we have active management of the heart on the system by our team, we can go any distance and as long as needed.
So basically, once the heart is in the machine and properly perfused and functioning well, there is no trigger that would make that heart unusable. In theory, it could be indefinite, right? I don't want to.
Yeah, in theory, but practically speaking, there's no patient that they would wait for 2 days or 3 days. This will be more for the research projects to have genetic modification, to do better allograft matching, but not for the actual transplant procedure today. For the transplant procedure today, 12 hours we've seen is more than enough. In fact, sometimes we see that for that staggering of cases, we've seen for liver specifically and lungs, that volumes or centers that have volumes that are growing with OCS, they would bring the organs on OCS, and instead of the organ bank, they would station them in the OR until they finish the procedure and then get to the next organ. We've seen this quite a few times now across the country. So we're heading towards longer times on OCS and longer potential stationing of organs on the system to be able to do more procedures.
And again, for those of you that don't all live this day to day, you'd be amazed what we can do in 12 hours. Like I can get a kidney from Hawaii to Boston for a recipient who's in Cape traffic in about 8.5. So anything's possible. Any collaboration with drone deliveries or other innovation Roger wants to know?
Drone is out of the picture for now. I see drone potentially once you have a fully automated logistical network that you just put an organ on a system and ship it by drone. I think we're far from getting there. This is years in the making, but you need a lot of modifications to systems like ours, for instance, the OCS, to be able to have it in a much smaller size and a very communicative way, to be able to load it on a drone and leave it to travel on its own. We potentially will get there, but we're still not that close.
What would happen to create a bank if you cannot keep the organ over 12 hours? What would have to happen to create a bank if you can't keep it over 12 hours?
Well, we'll station it for 12 hours. And 12 hours, I'm just quoting the number that I've seen so far in the US. We've gone longer outside the US, but I just don't want to claim data that hasn't been achieved here in the US. So time is not the issue, Glenn. It's really management of the OCS heart and being able to allocate to another center. Because the longer you wait, this means that the accepting transplant center is not existing. So you always want to get into the centers and make sure they accept it for transplant.
Great. That's all the questions we have in the chat. Hamid, anything else from you?
No, I'm just amazed. And I'll just share a personal, I was at a different event yesterday at the part of my function for HeartBrothers, and the organization was talking about advanced, out in the future therapies to cure the cardiomyopathy, the disease of the muscle and stuff. And actually the discussion of OCS came on, of the ability to keep a heart that maybe is not qualified to be transplantable, but it can be kept in it alive, if you will, what they can now do research on, and what the heart is alive and it's still beating, and they can see the effects of different treatments and medications and stuff, which is just a totally different aspect of this device that I don't think has fully been explored yet.
We're working on that, Hamid, you're right. And there's multiple academic institutions that are working with us on the research side, looking at genetic modification of the myocardium, looking at immune suppression and reaction of the myocardium and other organs, chemotherapy in case of tumors for all organs, including the heart. So there's a multitude of research, because just keeping an organ outside the body in a physiologic condition just opens the door to unlimited possibilities of treatments of these organs in the research world, and then translating this into the actual clinical world. But I don't want to claim something. We have publications that came out already from very strong academic institutions on genetic modification on the OCS, and we're proceeding. We're not just stopping here, but transplantation is the low-hanging fruit for all of us today, by benefiting more patients on the waiting list until we can further develop the research aspect of our technology.
Great. Well, as always, we want to thank HeartBrothers for hosting this. We want to thank Dr. Tamer, Khayal for helping educate us. And personally, I just want to thank all the patients that showed up tonight, because you are what inspire us to push the limits and find a better way.
Thank you to HeartBrothers, to you, Melissa, Hamid, and all the participants today, especially, as Melissa said, patients who are encouraging us. And our mission, guys, is really to save more lives. All of us here on this webinar and extended teams beyond here, saving more lives. And it's doable. This is doable.
So if there are no more questions, if everybody's questions got answered, I want to, on behalf of HeartBrothers, thank Dr. Khayal and Melissa. Phenomenal job. What a wealth of information. So much hope for us patients and the patients that are still in the earlier stages of heart failure that eventually will get to this point. So I just wanted to share with everyone what we have upcoming at HeartBrothers on Wednesday, November 16th at 5:30 in the afternoon, same time. We're going to have a post-transplant care webinar with CareDx. They're going to talk about, so after you get your transplant, then the various nuances and about taking care of the organ, various testing, or basically follow-ups that are available to make sure that after all the efforts have been expended to get a heart into somebody's chest or an organ to somebody's body, how to take care of it so it lasts a long time. We're also working on to have it basically heart failure transplant medication, a chat with your pharmacist. We're trying to find the proper pharmacist from a transplant center who can come, and once we get that all lined up, work out the logistics, we'll be announcing. And by all means, reach out to me, reach out to HeartBrothers if there's specific subjects, information you want to hear about, let us know, and we will go and find the subject matter experts and bring them to you. Just if you go to the HeartBrothers website, there's a number of resources available, from patient assistance request form for people who need financial assistance, to the HeartBrothers House. We have housing available in Boston on a first come, first served basis, which we had more apartments. We only have 2. We have the patient support group, which is a monthly virtual meeting that I sort of coordinate with. It's the second Thursday of the month at 6 o'clock. And just so everybody knows, on that particular one in November and maybe December, I'm going to have some mental health professionals to sit down and have a one-on-one chat with patients. We have Team HeartBrothers. If you have an interest, we would love you to become a member of Team HeartBrothers. We're always looking for help, and it's a great it's a great avenue, at least for me, and I know for many of us, has been to give back to the community and to the doctors, you know, give back to patients who are traveling that well. We have a section, books we love. We have a section called Therapist Finder. Again, one of the parts post-transplant that's not talked about much is mental health. We're trying to bring visibility to that, put focus on that, and make sure that we're providing resources or identifying where people can go to get resources for mental health. And then helpful websites, apps, and brochures on our website. And how you can contact us. HeartBrothers.org is our, is our website, at HeartBrothers Foundation, Facebook at HeartBrothers1 for Twitter, and at HeartBrothers. Keep forgetting what that symbol is.
That symbol.
Oh yeah, thanks. So with that, thank you. It was great having you. Again, to Melissa and Dr. Khayal, thank you so much. You guys just made it a special, perfect event. And to all the patients and your great questions. Thank you, thank you, thank you.
Appreciate it. Thank you.
With
Take care,
that,
everybody.
I'm going to end the session and see you guys in a month.